Setting up a meeting done. Okay. Good afternoon. I'm Mairead Painter, the State Long-Term Care Ombudsman here in Connecticut. Just coming to you today. We have an in-service related to, I shouldn't call it an in-service, an education series related to abuse and neglect. I'm joined here this afternoon by Brenda Texidor. She is one of our regional ombudsmen in sort of the central Connecticut, greater Hartford area. So I want to welcome you, Brenda.
Thank you. Thank you. It's so nice to be with all of you tonight. I'm going to talk to you a little bit about abuse and neglect in nursing homes, which also applies to assisted livings and residential care homes in the state of Connecticut.
Thank you. And I wanted to also say that on the 15th, so yesterday was World Elder Abuse Awareness Day. And so I think this is a very timely education series. You know, we've moved our platform from sort of, it was all based on COVID and the response that we were having in our state to COVID. Now we're moving to this monthly education series where we'll provide information, and this information will remain on our website so that people will have access to it moving forward. And if you have questions or concerns related to abuse and neglect, you can refer to the PowerPoint that Brenda's going to share with us today, and help educate yourself or loved ones in long-term care communities. So we are going to share PowerPoint, and then Brenda, you can walk us through it. Can you see my screen?
Yes, I can. Thank you very much.
All right.
All right. Okay.
Here, Brenda, and I will advance.
I'm not sure I understand.
Oops. All right, sorry about that. Trying to turn off the phones here. Okay, so the long-term care ombudsman program, I am, like Mairead stated, one of the staff in the program, and I will be talking to you today about abuse and neglect in nursing homes. That also applies to assisted living and residential care homes in the state of Connecticut. And it's a pleasure to be with you tonight. So the residents' rights, according to the Nursing Home Reform Act of 1987, nursing homes are entitled to receive quality care. Nursing homes are entitled to receive quality care and live in all residents, I'm sorry, let me start all over. According to the Nursing Home Reform Act of 1987, all residents in nursing homes are entitled to receive quality care and live in an environment which improves and maintains the quality of their lives. This includes freedom from neglect, abuse, and misappropriations of funds. In Connecticut, the state statutes defines abuse, neglect, and exploitation as abuse means causing intentional pain or harm, but is not limited to the willful infliction of physical pain, injury, mental health, anguish, or willful deprivation by a caretaker or services which are necessary to maintain physical or mental health. Examples are direct abuse from the staff member, an intruder or visitor from outside facility, for example, hitting, pinching, shoving, force feeding, and sexual abuse, psychological or emotional abuse, for example, berating, ignoring, ridiculing, or cursing a resident, threats of punishment or deprivation. This also includes substandard care and often resorts in one or more of the following conditions: incontinence, dehydration, and pressure sores.
All right, so Brenda, related to this, one of the examples I would say we hear of, I would say more often than not in our long-term care communities, I think relates back to the threat of punishment. So sometimes residents feel they're told you have to do this or you're not going to be able to have that. And it sounds small, but when you are in a position of authority or have power over someone, like going to the bathroom or getting a drink or doing things like that, that kind of verbiage, even though I don't think it's always intended to be a threat, but it's not about how it's intended, it's about how it's received by the individual on the other end. And so, I think we often hear, I think people think of larger things when you're talking about threat of punishment, but it can be that small, right? Great.
Okay. Neglect is the failure or inability of an elderly person to provide for himself or herself the services which are necessary to maintain physical or mental health, or the failure to provide or arrange for provisions of such necessary services by caretakers. And examples of that could be incorrect body positioning, which leads to limb contractures and skin breakdown. Sitting in urine and feces also leads to indignity and skin breakdown. Lack of assistance with eating and drinking leads to malnutrition and dehydration. Poor hand washing techniques leads to infection. And I know in my cases, all of these apply. I get calls about having to wait for long periods of times, not call bells being attended to, so the resident has to wait, and they're saturated briefs. Also, I've walked into facilities during my visits where residents may need assistance eating and have observed sitting there for a while before someone can come unless I point out that the person needs assistance. So come across that most often than not.
I would agree. I think these are a significant number of the cases that are filed with us related to neglect. I'm also going to guess that a lot of the neglect is related to staffing patterns. So when we know that staff are, as they would say, working short or shorthanded, neglect occurs not because of willful intent of the individual, but the staff just can't physically get to everyone. And so that's more of a systems issue at the nursing home, a facility-wide issue where their staffing patterns need to meet the needs of the residents so they're not feeling neglected and experiencing these things, again, that all have incredibly negative impact.
Impact to the residents. Yeah. Exploitation is the act or process of taking advantage of an elderly person by another person or caregiver, whether for monetary, personal, or other benefit, gain, or profit. An example of this might be the misappropriation of property of funds. This is the deliberate misplacement or misuse of residents' belongings or money without the resident's consent. The stealing or embezzling a resident's money or property, not placing resident funds in separate interest-bearing accounts where required by law. And again, in this state, it is required that the funds not be commingled, so they have to be in an interest-bearing account. There have been cases in our department about stealing and embezzling residents' money and property. So we do see that from time to time. And then misappropriation of residents' funds as well. And it could be such as, they have cards sometime and they're taken and their funds are used up without their consent, or it's taken and something is purchased without the resident's consent.
And yes, these are hard cases we hear of individuals maybe people making decisions about their homes, selling homes, what's done with finances, and sometimes it puts the individual in a difficult spot with becoming eligible for Medicaid. So we do get some of these cases when it comes to their resident trust funds. So their patient need accounts, resident trust funds, whatever that's called, they should be receiving a monthly statement, and a detailed statement showing all of the money that was taken out and on what days. And the resident or the responsible party, if they have permission to take money out of the account, should be signing, and there should be a record on the receipt for what money was spent or was given to the resident, that they've signed for it, or if they purchased something for them. There should be a checks and balance in place, and that should all be given back to the resident or the responsible party to review on a monthly basis from the resident needs account.
Okay. So what's an allegation? A claim that someone has done something illegal or wrong that must be proven or supported with evidence. When the claim is regarding abuse, it should immediately be reported to prompt a timely investigation.
So go ahead, Brenda.
So we do encourage, if you're in the building, if you're visiting, if you see something, to report it immediately so it can be addressed immediately, because the longer it goes, the more impact the resident has. So it's always encouraged to report it.
I would say this is especially important in cases of physical abuse, sexual abuse. And unfortunately, we do have to talk about that in our long-term care communities, that if someone reports something, every allegation should be thoroughly investigated. Sometimes after periods of time, some of the evidence goes away. Marks or the resident's ability to recall events. Now, I also want to caution, when our office is told about something by a resident or a family member, we do need the resident's permission to move forward on that, as we're not mandated reporters. However, there is a way for you all to report that to the administration or to DPH through a FLIS complaint. And so when allegations are made, you don't necessarily, if you're comfortable with the investigation being done by the nursing home and at that time, that's fine, but you also have the right to put it in right away. You don't have to wait until after that period of investigation. So I just want people to know that as well.
Yep. Nursing homes are required to have policies and procedures to prohibit abuse and neglect. And per the Connecticut Public Health Code, number 1, report immediately by telephone to the Department of Health by a report within 72 hours of the event. Number 2, open an internal investigation within 24 hours of the discovery of an injury to a resident of suspicious or unknown origin or an allegation of abuse. 3, complete a protective services mandated report of Form W-410. 4, contact the police department as part of the investigation. If the setting is an assisted living, they are required to have policy and procedures in place, but they are not required to report to the Department of Public Health.
So they have different types of ways that they report what they have for findings and incidents in assisted living. But for the nursing homes, I know one of the things that we hear sometimes and people are confused about is why the police either do or don't come. And so depending sometimes on how the information is given to the police department, they may decide whether or not they need to come out, or they just give it a case number. You always have the right to speak to the police directly yourself and to ask to be seen by an officer. So just because the building called and the officer didn't come, I don't want people to think that they don't have the support of law enforcement. Again, it might be the information they were given or how they're interpreting the situation. If you call and give your information and why you're looking for a certain outcome, I think they would come.
So in Connecticut, who's a mandated reporter? Nursing home administrators, physicians, any person paid for care of a resident in a nursing home or a residential care home, and in assisted livings, any staff employed by a nursing home or residential care home, any residents advocate other than the representative of the long-term care ombudsman program, any employee of the community-based service providers, senior centers, home care agencies, homemaker and companion, daycare centers, and any person licensed or certified as a medical service provider who is a member of the municipal fire department. Any mandatory reporter that fails to report shall be fined $500 or intentionally fails to report shall be guilty of a Class C misdemeanor for the first offense and a Class A misdemeanor for the subsequent offense.
Yes, and actually there was just a bill passed regarding this, and there's another category related to people who drive, I believe it's paratransit.
Yep, it's paratransit.
For those drivers, it's really important because they are often in regular contact with residents or individuals in the community and would notice something, right? If somebody goes out to dialysis regularly, if someone has appointments they're going to, and when they're going, they identify an issue or a concern. I think that that's incredibly important, and I was happy to see that change.
Yep. Is the ombudsman a mandatory reporter? The role of the ombudsman is unique in that the ombudsman is to act solely at the direction of the resident. When there is an allegation of abuse or neglect, ombudsman encourages the resident or his or her representative to allow the ombudsman to report the allegation. But when the resident refuses, the ombudsman is not allowed. The ombudsman is the only entity the resident may entrust with information with the expectation of confidentiality. The Older Americans Act and the new federal rule for long-term care ombudsman programs state that the office representatives are not designated mandated reporters.
I think that's really important because many times people don't understand that about our role, and that we all have different backgrounds, right, and degrees. We are provided this protection for the residents through the carve out of the Older Americans Act.
How to obtain help and report? If you suspect abuse and neglect, help is available and there are agencies responsible for investigating resident abuse and mistreatment. You can tell the facility administrator, social worker, or a staff person. You can certainly contact our office, the Long-Term Care Ombudsman's Program. File a complaint with the state licensing certification agency. In Connecticut, the state agency is the Department of Public Health. Contact Protective Services for the Elderly. Contact Connecticut Coalition for Elder Justice, and contact local law enforcement. It could be a crime if there is willful intent.
Thank you.
So report what you see, observe, and hear. Your reporting will stop the abuse and neglect and help someone.
And I think it's important to recognize people's tension levels as they're rising, so it doesn't get to a point of abuse or neglect. Sometimes people are afraid to say something or afraid to become involved. When you hear someone getting extremely frustrated or worn down, if you're in a building, if you're a staff member watching this, maybe offering to help your peer and give them a break if they have a lot going on, or there's a resident that is maybe very heavy care and they seem frustrated for some reason. You're going to want to intervene so that something doesn't happen. So really being support for each other. And then if you're a resident or a family member and you hear a staff member that you feel is escalating, go to their direct supervisor or a manager, again, the administrator, the social worker, and just address, like Brenda said, what you're hearing and seeing and observing, because you really could prevent someone from being abused.
And lastly, there are some additional resources. If you're interested more on the topic, you can look at the Connecticut Protective Services web-based training from mandated reporters, National Consumer Voice webpage regarding elder abuse, and the Coalition for Elder Justice in Connecticut.
All fantastic resources and have a lot of links to other information that can be extremely helpful for individuals. All right. Brenda, I want to thank you so much for putting that together and for sharing the information that you had with the general public today. You know, I'm excited to have the opportunity to have our regional ombudsman all offer their expertise, and this is certainly an area where Brenda excels. If you want to give a little background, Brenda, how long have you been with the program?
I've been with the program for 14 years.
And have you always worked in this region?
No, I've worked in the New Haven region and in this region now for the past 6 years.
So we have some people online, one thanking us for doing this today and getting the information out. So I want to let you know that. And then Amy has a question. How is the state responding to understaffing issues that we know are resulting in the neglect you are speaking about? That's a tough one. Mm-hmm. So during session, staffing requirements were increased from 1.9 hours a day to 3 hours a day. Our goal was 4.1 hours, but I felt like the opportunity was there to get to 3, and that maybe if we demonstrate that there still are concerns and gaps, that eventually we'll be able to get to the 4.1, but we haven't been able to make that large leap all at once in the many years that we've been advocating for that change. We know that there's also a really big gap in resources related to staffing. There just aren't the people going into this as a career. And part of that was due to the pay and the financial reimbursement and a livable wage. We were just talking about this morning as a team and saying that now, hopefully because of the money that was put forward by the state to hold off the strikes, and that individuals' pay will go up to a livable wage and have the ability to be seen as professionals and move forward. Maybe now more individuals will go into this role and we will have access to more staff. Unfortunately, we see many buildings where the census levels are dropping. And when they do that, they do cut back on things like staff. But when you have a lot of buildings with low census, it also puts them at risk for closure or to downsize. And that will change staffing demands as well. And so all of this is happening at once. So I can imagine that there's a great impact in the long-term care communities and what you're seeing and feeling as residents and family members. And so it's even more important that we have the ability to hear from you, to understand that, and to communicate that back to the Department of Public Health, the Department of Social Services, and representatives.
And just to add to that, when we do go into the facility, I look at the staffing sheet for that day. We do speak to the residents. If there's family there, I take the opportunity to speak with them. And that's another way we could get a feel of staffing. If there's shortages, and if there's so, I address it with administration at the time of my visit.
That's an important point too, Brenda, the staffing sheet. I don't know if people know or residents know, they always have the right to access that sheet. It should be kept in a spot in the building that is easily accessible by residents and family members. And it should be updated every shift for exactly who is in what they call the house, right? So whoever is in the building working at that time, it cannot include certain types of administration or people who go out for appointments. They shouldn't be counted in the total number. And then there's a formula that will be coming out with the new legislation to say what portion of the day should have people working, right? So what 7 to 3, 3 to 11, or 11 to 7. How many staff at least have to be on in order to appropriately care for the number of residents. So you always can ask for that. Sometimes we even get resistance in getting it, but that was passed in 2019. Has to be accessible, and what the formula is right now for the 1.9, but that will change with the 3.0. Let me see here. So if people have questions, if you want to put them in the comment section, we can try to address them. So we've heard throughout the pandemic, there were a lot of concerns related to abuse and neglect. I would say more neglect than anything else, due to people having access to the building and being able to see their loved ones or support them. And we weren't able to get in, and DPH wasn't doing investigations. I will say now we're starting to hear DPH is out. They are doing their annual surveys, and they're also starting to do those investigations. If you get contacted, please make sure you have all the information ready regarding your complaint to speak to the DPH investigator. As much as you can provide for them in writing is extremely helpful. If you have any questions or concerns about that process, how it goes, please let us know. They do reach out to us, and we're trying to communicate, as long as we have your permission, we want to communicate what you've asked of us in order to have that accountability, where we felt people did not have that in the past year. So Deb is asking, so if there are shortages and nobody applying for jobs, seems like there's no solution. So it does seem challenging, Deb. I get that, and it's a challenging situation. I did go online the other day just to be able to see what buildings were looking for what staff, and by nursing home associations. And thought it was interesting. I saw a lot of sign-on bonuses. They're trying to incentivize people in other ways. And we had the opportunity to speak to the governor a week ago, Brenda, about a week ago, probably.
Yep, a week ago.
Directly, and talked to him about some of our concerns. And one of them was related to staffing. And what he said was that there is a plan with some of the money that the state received, some of the COVID money, to look at workforce development. We know that there are huge gaps there. And again, it's about helping people see these as careers, that it's a ladder, that they have the opportunity to move up. And then we need to really believe in that and move people up, right? Show people that it is that career ladder. Let's see, sorry, just joining. I checked in too early at 4 p.m. No problem. So if there are shortages, what are your procedures? Staff in the past, when asked for numbers for CNAs per floor, it was challenged and staff were very reluctant to state. What should the inquirer do? So you can actually ask for that in writing. And somebody asked me for it recently. I think it might have been somebody on here. If it's helpful, and it sounds like it might be, I'm going to ask Dan, again, I can't multitask, so I'm going to write this at the same time, to include it on our website, the verbiage and the legislation, so you all can refer to it. You're addressing, and then I would say, oh, it was Avi, I thought it was you, but I didn't want to call you out on here. So when you're going to the building, if you get resistance, you could always print that out and have it and say, nope, you are required. If they still don't give it to you, or you're not seeing it posted, it is supposed to be posted and updated daily. It is a requirement. I've had some family members ask daily and chart it and send us what is given versus building. And then we have made reports to the Department of Public Health for inappropriate reporting of staffing. That is one thing that can happen. We also met with the nursing homes, and I addressed this with Barbara Cass to them. about the importance of having updated staffing sheets. One of the things related to staffing is that buildings have to staff, like we said, to the 3.0 now, or to the resident's acuity. And in the past, it has been challenging to show resident acuity because in all cases, it wasn't documented well. Moving forward, as nursing homes move to a platform where they are going to be paid, it's like an acuity-based payment rate. So they'll be paid depending on the acuity of that resident. It would incentivize them to appropriately categorize the person for the acuity that they have. But then again, it also requires that they staff to that level, and we have that as tangible information about those individuals' needs. So I think that will be helpful as well, and that will come, we'll start to see that more in the fall. What is the best way to establish a rapport with the resident when you are addressing abuse or neglect allegations? So rapport, I don't know, Brenda, you want to take that?
Okay. Well, when I get a call about abuse or neglect, I go in, I introduce myself to the resident, talk to them about our program. The first thing I also tell them is that whatever they tell me is confidential. I look around their space for family picture and just have a nice dialogue first. And then talk to them if there's anything they would like to talk to me, how they're doing, how is the care, what's their feed like. And usually they will open up to me and they'll tell me in the beginning, I want to talk to you about this, but I want it to stay between you and I. And that's perfectly fine. And I assure them that's the way it will be. And that's the way I built a rapport. If they're not ready at that time to address it, I will just leave it alone. I'll come back. I'll keep in touch with the resident and just continue to talk to them and encourage them to the point that they may get to that point where they say, Brenda, and just maybe by the mere fact of you coming to visit me, things have improved. Maybe not. If it continues and they feel comfortable with me, they will then give me the permission to proceed and address it.
I think that's a key piece, is that from other ROs as well, that we're not like a visit, a one shot, and now sometimes we can sense that the resident isn't comfortable. They're not in a place to just open up to us. And so it may take more than one visit.
Exactly.
A home that has an advocate, a resident advocate there, one of our volunteers, they'll make regular visits to build that rapport, because these individuals feel very vulnerable, and to just give us their information, someone they don't know, can be challenging. When I was a regional ombudsman, I often thought it was easier for me when it was someone who had been in the building a while, because we already had a rapport, right? So the regional ombudsman visit the nursing homes once a quarter, and they walk around the units. They might do education with the resident councils. And so, especially Brenda's been here 14 years, that it's a long time. Some of these residents have been in these homes for years.
Mm-hmm.
Residents who maybe aren't trusting of the system, have concerns, or have recently experienced a trauma. Those are the residents I used to feel needed more support to get to learn what our program did, how we support them, and why we were coming to see them. Let's see. So someone said, thank you. It's a touchy situation. I agree with you with asking for that information can be touchy in a building. People can feel at risk. So if we give it to you, then at least you have it. Marianne says, my husband passed away almost 2 months ago. I'm so sorry to hear that, Marianne. I'm a retired nurse and I did a lot of care for him. I was a fierce advocate. I worked within the system politely. I had difficulty getting individualized care for his diagnosis. I'd love to talk to Marie. Marianne, you can absolutely talk to me. Let me see if I can actually do this at the same time, which, again, I don't have Dan on tonight. And this is not Brenda and I, our wheelhouse here. T.gov. Did it work? It did. All right. So that is I just put in the thread my email address. You're welcome to email me. You can also always call us. We have a toll-free number, and we're going to be moving away. I just want to tell people this too. We're going to be moving away from the regional numbers because the staff are on the road so much, and our intake staff, we have 2 intake staff that are always calling other phones to get the voicemails to call you back, and then giving the messages to taking the intake and giving it to the RO. So we felt that having our main number in Hartford and then a 1-800 number would maybe cut down on the messages that had to be left, and you were more likely to get someone answering the phone. Now, I will say, because there's only 2 of them, they are often on other calls, but we'll try to get back to you right away. But my hope is by having less numbers for them to constantly be calling and checking messages and just checking 2 lines, that process will be a little faster. So we're just trying to find some efficiencies, and I'm hoping that that's one of them. And it might be easier just to know one number, and the number is 1-866-388-1888. And I will put that in the 1-866-388-1888. Oops, I typed it wrong. 1-888. All right, so I put that in the thread as well. Let's see, can you further explain this new acuity measurement? Yes. And for caretakers who are concerned about staff shortages, how best to proceed? All right, so the acuity-based payment is going to be driven by something called the MDS, the minimum data set. This is something we've talked about a few times before, but that is the tool that's used in order to measure the individual's needs. And so it's done every quarter, right before the care plan meeting. And then things that it's called triggering, things that come up on that care plan, on that MDS, are then the things that they're supposed to care plan for. The MDS asks things like, what type of assistance do you need in order to use the bathroom? How often does the person go to the bathroom? Can the person independently walk 50 yards? What assistance does the person need from laying flat in the bed to sitting up, to putting their legs over the bed? So it might say supine to sit. So there's different words in there, but it basically means, how does someone lay down? How does they sit up? Can they sit to stand? And how much assistance do they need? We know that the more assistance someone needs, right, the higher their acuity level. The higher someone's acuity level, the more staff they would need. So that's how the payments are going to be based moving forward for long-term care communities, for nursing homes. That's important because then if they're receiving that money, they should be putting it into the staffing, right? So this is going to be a system that happens over time. There's also, one of the things that I've asked for, there's some value-based payments. And so this is something next year that I'm going to ask you all to advocate for during the legislative session. I'm going to see if there's a way we can tie into this, or if we have to just advocate with DSS, that value-based payments. Nursing homes can get a little bit of extra money when there's quality for certain things or there's value seen. So I have asked that the 2 areas of quality or value that be addressed. One is related to staffing, so that nursing homes that have higher staffing levels over the quarter maybe get that incentive payment, they get a little bit more, right? So they've done a good job, they've met their threshold, they get a little more money. And then also that they can also get a value enhancement due to quality surveys by residents and family members that would go directly to the department. And so in order to get those, there would have to be a measurable way or a certain threshold to respond to survey questions directly from you all, and then they would earn, right, that sort of, I wouldn't call it a bonus, they're calling it a value payment, maybe it is a bonus, But that would go directly to the nursing home and could further enhance, again, the staffing, quality of care, dignity, because those are all the types of things that we want to have measured. So that's kind of where that comes in. If you're seeing staffing shortages, I would have a conversation with the administrator and the director of nursing. We had someone reach out to us today regarding the new technology bill and the ability for residents to access the technology of their choosing in their room. And that does include cameras. And one of the things I'm going to be interested to see, I actually don't think we are going to see as much blatant abuse. That's my hope, right? That we're not seeing as much blatant abuse on those camera videos when they're being turned in. But I'm going to guess we are going to see staff that come in and say, you know, I want to be able to help. I can't help right now. I have someone else in the bathroom. I'll be back. Food sitting for a long time because they're working under difficult conditions and not with the appropriate amount of staff. And that's what we'll be able to use to prove our point to say staffing levels in this building are not meeting the standard, the individualized needs and acuity. I hope that helps a little bit. There's a thought of paying CNAs more money, and I am correct. This legislation is slated. Is there a thought of paying CNAs more money? And I am correct. This legislation is slated. I don't know if I understand that. Oh, slated for the January 1st, 2022. I have to look at the timeframes of what came out related to the union. And so what often happens is when union contracts that size, that many buildings, the governor came out, he moved forward with a plan. The union contracts were signed. And so those buildings will progress as scheduled in their contracts. We see, so in the budget, you'll see there were increases for nursing homes, and that would be across the board. The other nursing homes often give the same wages or almost exactly the same, or the threshold is a tiny bit more, because if they didn't, all the buildings would go union. And that is something that many of the nursing homes, that's just a nursing home thing to either have union or not have union. But competitively, they do try to pay similarly in order to keep your staff, right? Because then everybody's going to leave and they're going to go work in. So those are the types of things that we see happening and moving forward. And we will be getting all of the dates and when things are supposed to be implemented. Sometimes it's on passage. Sometimes it's by July 1st, October 1st, or January 1st. So once we have that all finalized and everything is signed, so it passes and then it goes to the governor's office and it has to be signed. Once we have word, everything is signed as we expect it to be, but that's the sort of when they say signed, sealed, and delivered, we will have something on our website when to expect each of those bills. The other thing I will caution you about, and the question we got related to the technology bill, is our office has to work with the Department of Public Health and the industry to develop the forms and the confidentiality information that we're going to post it on our website and will be accessible for you. That has to be signed ahead of time. And it just passed. And once the governor signs it, we'll start working on those forms with DPH and the industry and get them out to people, and we will meet the timeline. Okay. Is there any update on a COVID case in long-term care with the extremely low transmission rate, or is it still the same flow chart? We are all terrified of being locked out again. So I understand that cases are extremely low right now. We have, we're not seeing people having to go out to the hospital at the same rate, maybe one here or there, deaths, things like that. Thank God we are on the other side of that. We did see here in Connecticut an essential caregiver bill pass, as well as a visitation component. I will tell you all here tonight that a federal bill related to essential caregivers has been proposed. and is moving forward. So Representative Tenney's office from New York and Congressman Larson. So I think it would be really nice if people reached out to Congressman Larson's office, who is supporting the bill, as well as I believe there's 10 congressmen and women across our country. I've been working with them on this and have talked with different committee members, and we'll be working on it in the next 2 weeks. You'll be hearing more related to information about how to contact your federally elected officials, national officials, to get support for this. I've talked to Senator Blumenthal's office, actually everybody's office, every senator and congressperson's office in our state, I have talked to and expressed the need to have this bill passed at a federal level. So the federal bill has other protections. We don't know, right? So there's always things that are proposed and then it goes through the wash and something comes out on the other end. Currently, the proposal is that at least 2 people in the individual's life would have access to them for at least 12 hours, up to 12 hours a day, as long as it didn't impact another resident. So you may have to go to the lounge, you may have to go to another area, but you would have access to that person. That's incredibly important. Some of the concerns that came up were related to maybe not having all of the information, like what if the person visiting we notice is abusing the resident, right? So this is good for here. None of the rules and protections of a mandated reporter, which the nursing home is, all of a sudden there's a bright light there, change, right? So if they feel someone is abusing a resident, they need to report that, they need to safeguard the resident, they need to call the police and have an investigation done. And so all of those rules are already in place. We're not creating new things for nursing homes. And so that would continue to be the expectation. But I'm gonna hope, and 99.9% of the time, the people a resident has acknowledged as their responsible party or their next of kin are not the people that are putting them at risk. It has happened and sometimes it does happen, but we have mechanisms in place to address that. We have probate court, we have other things. But I don't want to not do something because of the risk of a 1%, right? We have to do what's best for the greater community. And I think what's best for the greater community is to reduce isolation and to have them have access to their loved ones and friends. Increasing long-term care staff is great. Equipment such as a lift can help a lot too. I agree. Are provisions to add or improve equipment progressing? Wow, that's a fantastic question. And so one of the things that I don't know if you guys ever tune into the right size rebalance, long-term Medicaid long-term care right size rebalancing steering committee meeting. It is the first Friday of every month. I'm the co-chair of that committee, and they should be posted. If you Google it, there should be a site on the DSS site where the minutes pop up, or you can watch it, or you can ask that unit for it and they can send you the minutes. But one of the things that we've been discussing is there are a lot of dollars that have come to the state through the American Rescue Act. And one of the requirements is what we can do to help, right? Community members, help residents. They're also looking at through NAWLOG, the Nursing Home and Assisted Living Oversight Work Group. We looked at what infrastructure in nursing homes needed to be addressed. And one of the things that came up is the access to technology that allows for the highest level of independence and autonomy. So in some nursing homes, very few, there is something called a track system in the ceiling where the resident sort of has a Hoyer pad on, but can independently use a remote to lift themselves, to reposition. My dog is scratching. To toe touch over and lower themselves into their wheelchair. They can also hover over a toilet or in front of the sink in order to be able to brush their teeth, wash up, go to the bathroom independently without being at risk for falls. So there's a lot of things that technology can do. One point years ago, Brenda, you and I think you were with us, we went up to a home in Massachusetts that used technology in an incredible way. And individuals, did you go with us?
No.
Chelsea. It's in Chelsea, Mass. And individuals, so if you look at Brenda's glasses, like right on the side, there can be a little silver dot, and it helps them control the shades, which would be helpful for me to have right now, the TV, to make a call, all of those types of things. So yes, technology can be huge. The use of technology in a resident's room, I think, yes, we passed it. I think some people we're just thinking of cameras. This session, expanding that, I think is going to open up people's worlds. We've been talking about I'm going to say it and it's going to turn on the Echo, Alexas, those things, type of technology like that allows for someone who's voice activated to ask a question, to gain information. And our program in hopefully August, September is going to start to have podcasts available. And my goal is for them to be available and educate residents just to ask their questions to those devices, and then have that device give the answer through us. So they could ask, what is my right regarding visitors in a nursing home in Connecticut? And one of us will come on and say, your right is blah, 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 or contact our office. And some of them are LinkedIn and have the ability to just ask to call us. So there's all kinds of crazy smart technology out there to help keep residents safe and independent. And I think we need to use that more. Does your guest receive many reports of abuse? What has been her experience? So Brenda, do you experience much abuse? And I skipped one. And what's your experience around that? Like, I would say categorize it. The strong physical abuse, do you receive many of those cases?
Physical abuse? No, I don't see. I mean, some, but not a lot of those. No.
And
so like more so is like suspicion origin of like a bruising. Those come across more often than you know, intentional. Yeah.
And I'm thankful to say that we do not get many instances of sexual abuse. Unfortunately, we do, and it does come to us, and we try to support those individuals to the best of our ability and get them all the information and connected to services. So that it is something that has come up and we do address. But I'm fortunate to say it doesn't come up often. But our team members are all very aware and trained in that. And we take every allegation as true from the resident and make sure it's thoroughly investigated. And then neglect, I would say, comes up the most. And exploitation, I kind of find that it ebbs and flows. I think we get the most, and correct me if I'm wrong here, Brenda, the most exploitation cases right before and right after the holidays. Because people are struggling for money for the holidays. And then after, sometimes, unfortunately, we hear in nursing homes about Christmas gift or holiday gifts going missing. And that's a misappropriation of someone's property.
Mm-hmm.
All right, the question I skipped. I understand now better about acuity measurement, well, what acuity measurement is. Most, not all residents have need for assistance, correct? I just wonder how you hold long-term care facilities that they do want, or that they do what they say they do, not meaning to sound disparaging. Okay, so what would happen is when they score someone in the MDS, and then when the Department of Public Health or our team members are in, if they're not doing what they scored them or how they scored them when they're watching, and I know they're not always there to watch, but that would raise a reason for concern, right? Or if they say, well, the person fell ambulating independently. Well, the score on the sheet says they're supposed to have assistance. So it's just one more tool, right? It's not foolproof. We don't have any magic wand, but all of these measures and mechanisms layered on top of each other give the best opportunity to help address the concern. Congrats on getting the camera bill passed. Thank you. Was excited to read about it. We were able to have things passed this year. The team and I have just been talking about this, that we have been working on for years. Yesterday, we had a press conference with the Lieutenant Governor related to World Elder Abuse Awareness Day. And I thanked our elected officials, our public officials for really honing in on the concerns that they were hearing and addressing them formally in new legislation that makes sense. And one of the other bills that passed, and we're one of the only states in the country that I know of right now that has it, is the bill related to the ability for residents and family members to testify in a way that meets their needs and accommodation, right? So they can do it virtually, and that they need to be able to hear about the changes that are going to be made at a state level regarding policy, special groups, and how that's going to happen is it will happen through our office. We are working, and I know there's individuals on here that have been working on a statewide virtual family council that will then feed down to like regionals or in the nursing home family councils, providing information, and then them getting information back to me. When we have an issue or a concern where I think people might want to testify or be heard, I will be contacting the family council group, the resident councils and the residents in the nursing homes, and having them put out information. If there are, I believe it said, final bill, there were so many versions of bills, I can hardly remember what was the final. I believe it says if there are at least 15 individuals who say they want to be heard on a bill, a measure, that they have to hold a hearing and give those individuals an opportunity to be heard, including virtually. And we did have members of our executive board of presidents of resident council provide virtual testimony as well as recorded testimony that they submitted this year. And actually they got written up in a national magazine as a best practice, and I thought that was fantastic too. Thank you for telling us about the essential caregiver status for federal passage. Yes, and I will keep you updated. I actually just about an hour and a half ago talked to Congresswoman Tenney's office. There's going to be a lot of press happening with this, a lot of momentum behind it. And so when we need that, I'm going to ask all of you to start making those calls and reaching out. We've had a really good partnership with AARP on that as well. And so I'm sure they will be sending things out and messaging along with us. I want to thank their office. They were a huge support to us throughout the pandemic and also throughout the session. The language in the Connecticut Essential Caregiver Bill is very disappointing. It leaves way too much up to DPH. I'm hoping the federal bill goes through because there are less loopholes. Deb, I agree with you. We didn't get all the language we wanted here in Connecticut. And you guys might remember back in like November, I didn't think we would. Connecticut, we're a fairly conservative state, and they are going to always look to the federal government and CMS and where CMS is on something, and they're not going to put something in place that they don't feel is supported by federal guidance. And so at this time, they don't have the federal guidance in place to support what we were all pushing for and what we think is the absolute need. And so that's why, and it's not that I don't count on Connecticut's elected officials, it's just their comfort level and how our process here works. I know that if we can get this passed at a federal level, it will be supported, it will be followed through on, and our Department of Public Health will absolutely make sure it happens here. But we need it there first, and we need to know that the protections are in place, and that one of the strong points is that it can't be waived, even in a pandemic, public emergency, no matter what, that it wouldn't be, it's non-waivable, which the other one wasn't. The camera bill is awesome. Staffing continues to be an issue as locked doors and having to ring bells to enter. Reach out to your regional ombudsman and let them know about the locked doors. We're at a point where we need the doors to be unlocked. And I know Department of Public Health did tell them, I'd say about 6 or 8 weeks ago, when they were still really monitoring at a higher level visitors and camping and all of that, that the doors could be locked. But I will have a discussion. If I'm hearing from a lot of people that that's happening and it's a barrier and that they feel it's preventing access in some way or information, again, no magic wand, but I can try to address it again for you. But what are the rules if a long-term care facility has a COVID positive case right now? Oh, those are the same, Amy. The rules have not changed. We have not gotten any new federal guidance. We actually had a meeting with one of the federal partners last week. And I was hoping he was going to announce something, and he did not. I've also talked to individuals at DPH about it, and they're not anticipating anything anytime soon, but no change. Now we know some buildings are very, very open. Some buildings have less accessibility, but I think it's getting better. When there's a positive case, some do that flow chart well, and some struggle a little more with it. So if you're in a building where they're struggling with that flow chart or they're having positive cases, please let us know. We know that the vaccine does not prevent positive cases, right? It prevents the extreme illness that people were experiencing causing death. And so I'm not expecting to see no cases, but we've seen in Connecticut, I think it was down to 0.5 or 0.3% positivity rate. So it's incredibly low, so the transmission shouldn't be nearly as concerning. When will it be legal to have an Alexa in a residence room? Was it October 1st?
Yeah, October.
I think it's October 1st. Now, it doesn't mean you can't have it now, okay? So just so you know, there isn't anything preventing you from having it now. It just says that in order for a resident to have it, you want to make sure. The issue came up that, and I didn't know you could do this, some of the devices you can listen into a room. And so that's a concern. Residents deserve privacy. Sometimes they want to talk about something they don't want their husband, wife, sister, brother, somebody to know that can just listen in, right? Maybe they want to have a private conversation even with their psychiatrist or their roommate. And so to allow for that privacy, they're trying to figure some of that out and the details, and that the roommate would have to know as well, because you could hear into that person's in privacy. There is a way to, there's a button on the top that's a microphone. And if you hit that, then you're not supposed to be, it's supposed to not be able to come in. So we're going to test it out. There is a place called Neat Marketplace, Oak Hill Neat Marketplace, that works on a lot of this. We had them come and do a session with our elected officials to talk about the accommodation of these devices and what we can do to use them in a positive way, but just make sure people are fully informed. The short answer is October, if there's any challenge to it. Do the current DPH guidelines prevent access to the residence rooms even if the facility is COVID-free? Yes. They cannot access the resident, you cannot access the residence room if they have a roommate, right? And you're going in for a regular visit, they should not be allowing the visit in the room. The guidance says that it is not advised. They should be offering a separate space. The roommate shouldn't be required to leave or feel like they have to leave the room so you can have the visit. Because it's their home, it's their private space. So that is the challenge around that, and that guidance has not changed. Wonderful answers, thank you. Oh, you're welcome. You're welcome, you're welcome. All right, and we are even a little past an hour. We started a little late today because I had some technical difficulties trying to work this out. Thank you, Dan Beam. Thank you so much, Brenda, for
You're welcome.
Coming on, being a part of the discussion, and answering people's questions. Oh, Amy scooted one in. Except administrators who won't allow them, right. There is a woman with MS, highly impaired, who just wants to listen to the Bible scriptures and really wants her Alexa back. That was taken away. I think it's cruel treatment. I don't have a magic wand for that right now. Like I said, maybe we can facilitate some agreement with that person, with that administrator. But again, it's not a given. We try to negotiate, but we don't always win. But come October, one of the things that person could do preemptively, Amy, is see if their roommate's on board. And if the roommate's not, they can request a room change and try to have that accommodation made in order for them to be ready when October gets here. All right. So thank you all. Brenda Foreman will be doing next month, I believe. And I believe the series she's doing education on is related to memory loss and diseases that cause memory impairment, and a lot of information around that. So that's really her wheelhouse. She provides us with a lot of support around that and does a lot of national groups. So thank you so much. And we will talk to you guys in a month. If things come up, we will definitely pop on. We will I have for Dan to put up the legislation relating to staffing, so you guys can have that, as well as when things are signed by the governor and they're official, getting them on our website so that you know the dates when things become effective and what the process is going to be in getting there. All right. I hope you have a great night, and we will talk to you in a month. Good night.
Bye, everybody.